Hi, I'm Dr. Cohen. Sorry, we need to keep on going, but you can grab coffee and whatever. Good. Okay, so today we are going to continue the discussion as what Dr. Hell said, and we are going to take a step back and talk a little about the challenge of a timely diagnosis. And we're going to do this through clinical cases, okay? Good. So the objectives that we have is try to understand why an early diagnosis is important, and we're going to have then another lecture on how to improve screening in primary care with Dr. Malas. We're going to review a little bit the stages, how we stage dementia, and I'm going to show you the instruments we use. And we're trying to see what is the impact of the non-diagnosis, in which way the families and the patients living with dementia are affected by misdiagnosis, late diagnosis. And at last, we're going to talk a little bit why it's important to recognize what it is important for the patients and what matters to the patients into the discussion. So we're going to do this through clinical cases, and we can interact, so it's less boring. So we have this patient that I saw in Social Memory Net. She is 68, African-American lady, and she's brought her by her husband to clinic. Her educational level is 11 grades, and the patient says, I'm fine, I don't have anything. And that's something that happens a lot. Many patients with real dementia, they don't recognize their deficits, so they're really brought up by their family members. But the husband says he was very worried. She is making mistakes with her medical appointments. She is making mistakes with her bills and finances. And she really forgets what she has to do. She is not speaking and interacting as much as before, and that's an early sign of dementia. At the beginning, sometimes patients have this social withdrawal. They don't engage and participate. And when we confront her with her memory problems, she gets very angry. So that's also common to have irritability when confronted. And on top of that, she has some sleeping problems. So past medical history, she had these symptoms for 5 years. And she's been making mistakes for the last 5 years with her bills. She was driving until a year before she came to see me. And she had this episode, and we call sometimes these catastrophic events. And what happened is that she was driving by herself. She got lost. She was not able to come home. She was very stressed. She was so stressed she couldn't use her phone. So they really had to call the police and help her to come back home. So this is like a bad event. So she has no history of head trauma, no history of alcohol or substance abuse, past medical history, hypertension, diabetes, osteoporosis, stable chronic artery disease, and ex-smoker. This is kind of the typical patients that we get. I'm also a geriatric specialist and I'm primary care, so patients with all these comorbidities, what we see. They have a list of different problems, and one of the problems is dementia. And no family history of Alzheimer's disease. And again, she is 68, but she presented with dementia symptoms 5 years ago. So we're dealing with someone who at 63, she already had symptoms of dementia, okay? So when I saw her, she was taking losartan for blood pressure, metformin for her diabetes, calcium and vitamin D, and metoprolol for her stable chronic artery disease. So we do a physical exam. Vitals are okay, but blood pressure is a little high. I did orientation, so the way when we do orientation, this is really taken from the mini-mental. So we score orientation with 5 points. So the first one is day of the week. The second is the month. The third is the day of the month. The fourth is the season, and 5 is year. So I usually like to score orientation out of maximum of 5, and she only got 1. Place orientation, she was oriented to place, but she didn't know the floor of the hospital. She was cooperative, but she was only speaking when I addressed to her. So mainly the conversation was with the caregiver, with her husband. Her language was fluid, but she had some word-finding difficulties. Her neuroexam was without normal deficit, and her gait was normal. So we do the screening test that you probably could do. This is easy, a mini-cog, and this is her clock. And she only got 1 point of the mini-cog. And we order some labs, and that goes to your question, what do you order? We usually order TSH, B12, vitamin D, we order chemistry, we order CBC. Sometimes we order serology for HIV, and sometimes we order an RPR to rule out neurosyphilis. That's what we usually order. And this is her results. And her creatinine was a little high, 1.2, so she had mild kidney problems. And her diabetes was not very well controlled, her glucose was 200 fasting, and her hemoglobin A1C was 9.5. So like a typical patient that we could see in primary care. So after that, I spent a lot of time, since I'm a geriatric specialist and a dementia specialist, staging and doing a functional assessment. So I like to do the functional assessment using scales. And you could pick, and we are going to have a few seminars today on how to stage and how to do the functional assessment. But in clinic, I usually like to use these two very basic scales because they are quick. So for the basics activities of daily living, I usually use the CAT index. So of a maximum of these 6 activities, you just give 1 point for each activity the patient is able to do totally independent, okay? Sometimes it's a little tricky. For example, with dressing. The patient could get dressed by herself, but she's picking the wrong clothes based on the day on the week. So in that case, the patient needs someone to supervise. So in that case, I put a 0 for that activity. If someone needs to supervise and help selecting the appropriate clothes, then that means that they are dependent, okay? And we usually do the instrumental activities of daily living. I use the Lawton and Brody. So these are these 8 activities, and it's really dissected into what you consider is dependent and what is independent. So basically, there's 8 activities, and you may be familiar with this: taking your medicines, doing the laundry, cleaning, shopping for groceries, managing your money and finances, using the telephone, which is very important, so they could ask for help, mode of transportation, driving. So of the 8, you give 1 point for each activity the patients can do independently, okay? So based on these 2 scales, and this is what I usually do in clinic, that helps me a lot, this patient was 5 out of 6. She needed some help with dressing, so she was able to do 5 activities of the basics, but she was 0 out of 8 on the instrumental, so she needed help with everything. So her husband was really supervising her with everything, okay? So I saw this patient in short-term memory net, so we usually start with a dementia-focused interview, that this is exactly what I show you, the functional assessment, and then we usually start with the MOCA, okay? So this is her MOCA, and usually the idea of short-term memory net is to do a full cognitive assessment, but if the MOCA is 12 or below, we don't pursue cognitive assessment because we know already the patient is impaired. So in this case, her MOCA, she had multiple domains impairment, and she scored 12 out of 30. And this lady had 11 years of formal education, so the MOCA was an appropriate test for her. So she's definitely impaired in all cognitive domains. And if you see here, I'm sorry I don't have a laser, but delayed recall is definitely impaired. She got 0 out of 5. So, which one is it? Sorry. This one? Yeah. Cool. Excellent. Thank you. So on the delayed recall, so here, on the MOCA, we ask them to learn 5 words, and we don't score here for the immediate recall. And then we distract them with all these tests, and then we go back to delayed recall, and she scores 0 out of 5. So she's definitely having multi-cognitive domain impairment. So we order an MRI, and I shall show you a few slides. So this is the sagittal view. We definitely see ventriculomegaly, and we see some atrophy, kind of diffuse atrophy, but definitely parietal atrophy. This is the axial T2, which is a really nice test to see white matter hyperintensities. So again, we see the ventriculomegaly, we see some cortical atrophy, and we see these large, big, white matter hyperintensity lesions, okay? So we usually score these, and we're going to have a lecture with Dr. Hels today, but we usually score these white matter hyperintensities as mild, moderate, or severe. In this case, they are moderate to severe because they are big and confluent. And this is a coronal test, which is an ideal test to see the medial temporal lobe and the hippocampus. So again, here we see ventriculomegaly, and this is where the hippocampus lies, and we see this big dilatation of the choroidal fissure. So this lady has significant hippocampus atrophy, okay? Good. So based on all this, we like to use a staging scale. And one of the scales that is easier to use is this one, and I present this to you. This is called Clinical Dementia Rating Score. So basically, you do this score, you interview the patient, You know the functional status, you know the temporal orientation, you interview the caregiver, and then you're able to go one by one in these 1, 2, 3, 4, 5, 6 categories, which are memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. And on each of these rows, you had to decide where I'm putting this patient. Is she mildly, for example, for memory, stage 1 would be moderate memory loss. Stage 2 would be severe memory loss, and stage severe would be severe memory loss. So what you do with this test, you go row by row, and you select each category. So based on this, you could actually determine what the CDR score of this patient is, and based on this is how you stage dementia, okay? In this case, we can do it. It usually takes like 5 minutes, but this patient in particular, she had more 2s than 1s and 3s, so she was really stage 2. That means moderate dementia. So my diagnosis at the end of this evaluation is that she did have early onset dementia, and we say early onset dementia is when the symptoms of dementia started before the patient is 65. This patient was 63 when she already had dementia. Not minimal cognitive impairment, but she already was making mistakes. She has significant white matter hyperintensities and significant cortical and hippocampal atrophy. Based on the CDR that I showed you just now and the functional status, we classify her as moderate dementia. And her most likely diagnosis could be mixed dementia because she had all these white matter hyperintensity lesions versus Alzheimer's disease. So my recommendations, control vascular risk factors. Her blood pressure was not well controlled. Her diabetes was not well controlled. She definitely needs supervision with all her instrumental activities of daily living because she was still making mistakes. I referred this patient to adult daycare program. Remember, I said she had a little withdrawal. She was not doing a lot of activities, and engaging and doing activities is probably so important. Of course, I recommended not to drive. She was already driving. And then we can talk, once I control better the risk factors, I would have started this patient on donepezil, and maybe later memantine. But this is what I did so far with her. So if we look at the progression and the continuum of a patient typical with Alzheimer's disease, it really goes from, usually we have this early stage of minimal cognitive impairment where the patients have cognitive symptoms, but the functional status is absolutely normal. Then they progress to mild dementia. As Dr. Grace Health says, the progression is variable, but usually the MoCA in patients with Alzheimer's decrease 2 to 3 points per year. Sometimes it's quicker, sometimes it's slower. Of course, if the patient had uncontrolled vascular risk factors, there is a lot of evidence that the progression is faster, okay? So then you go to this stage of moderate dementia where you have dependency in all your EADLs and some of your basics ADLs. Usually at this stage, you don't have many falls, you don't have urine incontinence, you don't have swallowing problems. And then you go to this severe stage of dementia that could really last up to 7 years, and it really depends on the care that you're getting. And at the end of this phase, you have motor problems, you have more falls, you have urine incontinence, and you're totally dependent. So based on what we say, this patient had moderate dementia, okay? And what is interesting in why she was not diagnosed, why we let her progress for 5 years without the right diagnosis, and what is the impact of this non-diagnosis of the family. So let's talk a little about Alzheimer's in minorities. So we know there are racial disparities in incidence, prevalence, and management of dementia in minorities. Dementia risk is 2 times higher in African American compared to white non-Latino population, and it's 1.5 higher in Latino versus non-Latino. So there is no doubt now that Alzheimer's is hitting harder minorities, okay?
Is that in the United States, or is that worldwide?
This is in the United States, but also worldwide. For example, in Latin America, there is this epidemic of dementia coming out because Latino are hitting especially hard too. In Africa too. That's why we're saying that worldwide, dementia is going to hit harder developing countries in the next 20, 30 years. And we can talk, there's a lot of literature on that if you're interested. It's very interesting why is this happening. But, oops, sorry, go back. So, is it due to racial, economical, literacy, socioeconomical, lack of vascular risk factors? All these are great questions. And it seems that all this together is what making this increased risk. What we also know is that, and this is very important, that misdiagnosis and later diagnosis are much more common in this population, okay? And I show you a few pictures of that. So is there a disparity of prevalent dementia based on race and gender? Yes, it is, okay? We know that almost 2/3 of Americans with Alzheimer's are women. And why do you think is that? Exactly, we live longer. And the main risk factor for Alzheimer's is advanced age. So it's much more, we have much more ladies who reach 90 or 85 than men, and that's why we have more risk of Alzheimer's. Good. But we know that, as I said before, older Black and Hispanic, much higher. And this is very interesting. These populations are hit harder, but there is underrepresentation in clinical trials, in biomarkers. So if you check all these anti-amyloid drug trials, maybe 2 or 3% of the population that they include and they enroll were from minorities. But these minorities are hit harder. So this is the paradox. This is what we need to fix. Good. And the Alzheimer's Association called this African American and Alzheimer's disease the silent epidemic. I just put the slides because I think the title is perfect. It's really what's going on. So what are the unique features in African Americans? So as I said before, they have much higher risk of vascular risk factors, diabetes, hypertension, smoking, alcohol abuse, sedentarism. There's no question about that. They have higher number of misdiagnoses. They have higher number of late diagnoses. And definitely, as I said before, educational and socioeconomic factors are playing a role here. So these are great. If you're interested in this in particular, you could read these 2 articles. They're really good about this. Good. So let's move to the next one. So, and we're going to have a lecture by Dr. Marlatz about this, why an early diagnosis of dementia is important. So I will let him to discuss this later, okay? But definitely, even if we consider, we now have these anti-amyloid drugs, but we know that many of our patients don't qualify for that. So even if we're not talking about a curative disease, early diagnosis is super important on so many levels. So like 20 years ago, when I started to be a memory specialist, there was some discussion, why do you want to diagnose a disease that has no cure? And that was kind of the feeling. You went to these medical meetings and say, why biomarkers? Like people were questioning, why we need to diagnose this early? Now, no one is really questioning this. We need to diagnose this early. Even if, as I said before, many of our real patients in real practice, they won't qualify for anti-amyloid drugs, we want to diagnose. We want to help these families. And we have all these wonderful resources. So early diagnosis is super important, and we're going to have a full lecture about this today. Good. Are we okay with the time, or we're running late? Keep on going? Okay, good. So second case, different case. 82, African-American male. He comes here, and he had cognitive symptoms for 7 years. He had slow, continuous decline. He needs supervision on a 24 hours. He walks slowly. And this is interesting. So he was brought to clinic to me after 7 years of these symptoms, and the family thought that this was really part of normal aging. Okay, and that happens a lot. And the patient was seen frequently by the PCP, but there was no diagnosis, no cognitive assessment, no neuroimaging, nothing was done. So on review of system, what I was really worried as a geriatric specialist, this patient was losing weight. He lost more than 10 pounds in the last 6 months, unintentional. He had a positive family history of Alzheimer's, no falls, no urine incontinence, no history of head trauma, no history of alcohol abuse, and his past medical history, type 2 diabetes, gout, hypertension, osteoarthritis, and diastolic dysfunction. Again, like a regular patient that we see in primary care complex. So physical exam, he had orthostatic hypotension. He was clinically euvolemic. His BMI was 24. That for an 82-year-old guy, it's a little low. And if we want, we can talk about that. This is a very geriatric concept, but we want our 82-year-old guys to be a little chubby, not with a BMI of 24, okay? There is a lot of evidence that people at 80, when their BMI is higher than 30, they live longer, okay? But this is a different talk. So he was unstable with a slow gait. I did a get up and go. He was very slow, 22 seconds. Temporal orientation, 0 out of 5. Place orientation, 2 out of 5. low fluency in his language, he only speaks when directed, and he was really sleeping during the visit. That happens a lot too. So he was taking all these medicines, amlodipine, losartan, furosemide, spironolactone, aspirin, atorvastatin, just to prevent, glipizide, metformin, allopurinol. So a total of 9 medications. So his labs, his diabetes was totally well controlled. In fact, kind of low, the hemoglobin A1C. Creatinine level 1.4. He had CKD stage 3B. He had mild anemia. His lights were normal. B12 was 250, which is kind of in the low. It's normal because it's normal above 180, but kind of low. And RPR and HIV negative. So again, this is what we usually order. So we do the functional assessment based on the scales I showed you before, and he's much more impaired than the previous case. His basics, he was 1 out of 6, so he's only able to eat by himself, and he was totally dependent on the EADS. So this is his MOCA. So he scored a total of 8. He had, again, multi-domain involvement. Sorry, this is not his clock. This is his clock. And he scored 8. This is his MRI, sagittal, a lot of atrophy, parietal, posterior, and also anterior. HLT2, he had very mild white matter, and he had diffuse, definitely diffuse, severe cortical atrophy. And corneal cuts, again, a lot of parietal atrophy, hippocampal atrophy, okay? So in this case, I was really focused on geriatric syndromes because this patient is losing weight, he's slow, he has an abnormal gait, so I'm more worried. I'm worried about dementia, but I'm worried about the whole picture. So I did a geriatric assessment because I'm a geriatric expert. So I diagnosed this guy with frailty. So the guy has low energy, decreased muscle strength, low exercise capacity, unintentional weight loss, and slow gait. So he's a frail older adult. I like really this scale for frailty. This is not dementia, but this is geriatrics. So he's losing weight. I'm really worried about this. He lost more than 10 pounds. Unintentional BMI was low. He definitely has polypharmacy. He was taking 9 medicines plus vitamins. And he had urine incontinence. So when you ask and you go systematically doing a geriatric assessment, you find all these very important symptoms that usually patients and caregivers don't disclose. So we have all these problems in this guy. It's not just dementia, it's the whole picture, okay? So what are my recommendations? Prevent and address one by one all these geriatric syndromes. I referred him to an adult daycare program. I focused on nutrition, false mobility. And then I had this discussion, which is so important, of asking the patient and the family member what matters most to you. And the patient said, I don't want to take that many pills. And the caregiver says, I don't want him to have so many referrals and doctors. I need help at home with him. So this was really significant for this family. And they're really suffering alone because all these issues were not addressed. That's why we need to intervene. So if we do the clinical dementia rating scale, this guy is probably here. He's at 3. So that means that he has severe dementia, okay? So now we need to focus on how can we help this patient and this family with severe dementia, okay? So my diagnosis, late onset dementia, significant diffuse cortical atrophy, hippocampal atrophy. Staging is severe dementia. Most likely diagnosis is Alzheimer's disease. And I'm super concerned about geriatric syndromes, weight loss, frailty, urine incontinence, low mobility, risk for falls, and polypharmacy. And he was taking 9 medicines. And he said that for him, what it was significant is not to take that many medicines. So we need, once you ask what is significant for them, then you need to address them. So what we did, based on that, I basically deprescribed. So he had diabetes, but his hemoglobin A1C was 6. And what is the evidence that decreasing hemoglobin A1C in someone with diabetes would prevent complications? And the evidence says that if you decrease the hemoglobin A1C, after 10 years, you're going to see decrease in microvascular complications. But this guy is 82, and he has severe dementia and frailty. So what is his life expectancy? 1-2 years? So what is the point in having such a low hemoglobin A1C? None. So I did see basically the glipizide, and I kept them metformin. I did the same with, he was euvolemic, he had orthostatic hypotension, blood pressure was low, he was having unstable gait, so definitely IDC furosemide, spironolactone, aspirin, because he was taking aspirin for primary prevention, there is no evidence for that, IDC atorvastatin, and IDC allopurinol. So he ended up with 3 medicines, which is better, that's significant for him, so we are helping. So we, geriatric specialists, we really like to help. Even if we don't cure, what we want is to help. So we are fine, not curing, but just helping. So why is it important to elicit patients' preference in older adults with dementia? There is a lot of evidence that this works, okay? And you can read the evidence. And this is also interesting. How many patients we see in real clinical practice have dementia and comorbidity? And the number is huge. So poor patients, like the ones that are included in randomized clinical trial, are really rare in our practice. Most of the folks that we see, they have 4, 5, 6 different diseases, polypharmacy, and all this complexity. So this is just to show you that in real practice, this is a big sample of 3,971 older adults with dementia in Spain. Most of them had many other diseases on top of the dementia, okay? The number of medicines, the number of diseases was 3.6, and the most common comorbidity was hypertension, diabetes, CAD, CKD. And this is exactly what I'm seeing I work at Grady with mainly African-American populations, and this is what we see. Very complex patients, very frail with all these comorbidities. So our goal is to put all this together, okay? So, how do you do it? You have patients with dementia and all these other diseases. Where do you start? So you definitely have to stage the disease. You need to base everything you do based on functional status, prognosis, and always patient's priorities, and always risk of adverse reactions, okay? So the idea is to do this flexible, patient-centered, and dynamic approach. So you do something, and then next visit, if it doesn't work, you modify, and that's okay. And considering patient preference, and I like this, instead of when you introduce yourself to a patient, and you usually ask, okay, what can I do for you? But sometimes, instead of asking, what is the matter with you today, it would be nice to ask, what matters to you today? So when you ask, you have all these answers that you were not expecting. So this is really interesting, and this is kind of my focus of my current research. So the idea is to do a personalized plan that is aligned with patient preferences. And there's these wonderful resources from the American Geriatric Association if you want to know how to put all this together with patients with all these comorbid conditions at the same time, how you treat patients with multimorbidity, and this is interesting. And at the end, what you try to do is you try to make a plan that is significant for the patients. So it really helped this patient, because then I saw him 6 months later. He was increasing his weight, he was not falling, he was doing home services, physical therapy, occupational therapy. I ordered a home aid, so he was doing better. Thank you so much. Do we have time for questions or no? Any comments, questions regarding this lecture?
I do have a comment. As someone also in this space, I really think it's really important that we focus more on the fact that there are social determinants of health and that we don't just focus on race. Because I think people get so caught up in the fact that, oh, we got an African American, without recognizing that there's so much more context around someone being African American in the United States. And I think we really need to pay attention to that and make sure we focus on that we don't get so caught up in thinking solely about race. Because we know it's not, it's a social context.
Definitely, and what I'm doing in my research, so there is a discrepancy, especially in Georgia and rural Georgia, between years of education and literacy level. So all these tests, cognitive tests that we do, they are adapted to someone with more than 6 years of formal education. But at least at Grady, I see so many patients who have 6 or 7 years, they don't know how to read and write. So how do you interpret those cognitive tests in this context? So my next research is seeing the discrepancy between years attended to school and literacy level. And I'm finding some very interesting things. So I'm switching my cognitive testing. Half of the patients, let's say 20 of the patients we see at the MAC at Grady, I cannot do the cognitive assessment. So I'm using different tests for non-literate patients, and that's working really nice. So we need to adapt.
Great point, because Dr. Jennifer Manley out of Columbia looked at it. And so what they discovered is in southern states, when you think about these older adults, they spent more time working in the fields.
Yeah.
So they didn't have the same amount of time in school, even though they were technically in the same.
That's why the question is how many years you attended to school. Sometimes it's not really valid. So a literacy level, that's what we should be moving, especially in this population. Thank you for your comment. Yes?
In your last patient, you discontinued the statin.
Yes.
What was the reason?
The reason is that his prognosis is based on frailty and on his severe dementia. So I usually use something called e-prognosis, which is a really nice scale to see prognosis in older adults. And based on his real prognosis, if your life expectancy is 1 year based on your frailty and your severe dementia, what's the point of giving a statin that's going to decrease the cardiovascular events in 10 years if this patient is going to live 1 year? And I consider what matters most to him. He didn't want to take that many medicines. He was losing weight, BMI was low. I discussed it with the family. I'm not saying it's right, but you know, it's just like a conversation. And I decided to say that.
Should he be referred to palliative care hospice?
Well, I'm a geriatric specialist. If I think I could provide good care, but maybe that's a good question. But I definitely implement all those services. And this was, I only saw this patient twice. I kind of like to see them a little more before I refer them, but that's a good question. Yes?
Also, you discontinued allopurinol.
Yes.
So were you not scared of...
Well, this guy, I didn't say, but he did, you know, if you didn't have a gout attack in 1 year, you're allowed to discontinue. That's why I did that. So no recent gout flares, that's why I discontinued.
Yeah, just to play a little bit of a devil's advocate for the other side, I understand they don't want medicines, and I get that. But the way I look at it is, okay, I look at what medicines could cause problems and are difficult to manage with memory problems. Insulin, oral sulfonylureas. So you get rid of them. But like if they were on pioglitazone and didn't have swelling or heart failure, I would leave it on board for diabetes. I would leave metformin on board. I would even probably leave allopurinol and the statin on board because they cost nothing. And they're probably going to get the blood work anyway that's necessary to monitor that. And then you won't have to deal with a gout attack or a cardiovascular event. And there's almost no negative. But I understand targeting the high-risk medicines like oral sulfonylureas, or if they're having myalgias, get rid of the statin, right? But I would be cautious because you can unravel their other medical problems trying to lessen the medicines. So I think it's okay to target things that have a lot of problems, but just to get the number lower, I'm not sure I would buy into that.
Yeah, in the case of diabetes, I mean, I want this guy to have a hemoglobin A1C close to less than 8. So I'm going to let him fly until he reaches 8, and then I will do something.
But with A1C, you're always going to get benefit at lower, and the risk is almost zero. And those studies that let the A1Cs be higher because they were worried about problems were hospital studies with insulin, with hypoglycemia.
I agree. It's just that when you ask what is significant to them, and then you had to listen and you had to do something.
And the mortality.
It's not, there's no right or wrong, and that's fine. It's just that once you ask and they say, I don't want to take that many pills, this is what making my life miserable, then you need to do something. And that's fine. You know, we negotiate. And the family has to be on board, of course. Yes?
Many of your screening tests
Yes.
looked at incontinence. What is it about dementia and memory loss that leads to this problem? Because that's a very common complaint.
Yeah, definitely. So and Dr. Ted is an expert on incontinence in older adults. But so with dementia, usually with severe stage dementia, moderate dementia, severe stage dementia, you start to see urine incontinence, which is very frequent. So definitely dementia has to do with increased risk of urine incontinence. In this guy in particular, he was taking all these diuretics, so maybe a lot had to do with that too. But, you know, incontinence is very frequent in geriatric population.
Or are they missing
This guy has severe dementia. When severe dementia, you get incontinence.
So it's a brain disease. It kills off the nerves in the brain.
Yeah, so you just get...
Eventually, it's going to stop all of the organs from working. Ultimately, it makes it fatal. And so that's what happens as it progresses in the severe state.
Good. Any other comments?
especially with patients with cognitive impairment, when screening for B12 deficiency, shouldn't we be ordering methylmalonic acid and homocysteine levels?
Yeah, that's sometimes.
Instead of
So
just
in this case, I decided to supplement it because he was losing weight and kind of on the low side. But definitely, yeah, like homocysteine level, and yeah, it's a good point. Yeah, definitely. Sometimes we order. Okay. Yeah. Last question.
Your presentation was great.
Thank you.
Concern about polypharmacy. My reason for bringing up the staff is because the patient did have diabetes, and the prosperous study show in the elderly that, keeping them on the statin sometimes decrease cardiovascular events, and we didn't want to try to treat one problem and open up another one.
Yeah, that's absolutely right. So I really base what I do. The prognosis is such a strong, so frailty, and if we have time, we could talk about that. Once you have the diagnosis of frailty, your prognosis is determined by frailty. So this guy's life expectancy is 1 year. What is the benefit of giving him statins? It's after 5 to 10 years, and that's my reasoning. But I'm not saying this is right. This is like an ongoing, and you could keep the statin, that's fine. I'm not against statins. I'm trying to do what is significant for these patients, and this is my main task. What I'm doing is significant for them, and I'm really helping them. So this talk is just to change a little bit where you're sitting and, like open your perspective. And there is no right or wrong. Thank you. Okay, thank you all.